Hey everybody, do you find yourself consulting Google to determine how to keep your clients and coworkers safe in this seemingly never-ending COVID-19 pandemic? Well, lucky for you, the guests in this episode have done the heavy lifting and they've thoroughly researched many of the best practices in risk mitigation in ABA clinical practice, and they are joining us to talk about it. That's right. My guests for session 152 include Doctors Zahra Hajiaghamohseni, Mary Caruso-Anderson, Jennifer Sweeny, Sarah Duarte, and Christy Evanko. These behavior analysts hail from all over the country, and they came together to develop a continuum of care screener, which is a tool that ABA providers can use to manage risk in their practice. In this show, we discuss what risk mitigation means, why the practice of ABA presents unique risk mitigation challenges, and steps providers can take to reduce the likelihood of becoming infected with COVID-19. We just cover a ton of ground in this episode, and this may be one that you want to share with your coworkers, supervisors, and anyone else who is charged with the health and safety of clients and staff members. It may be one that you want to listen to more than once as well. I know there are many nuggets that I didn't catch the first go around that I learned about when I went through the show again in post-production. So again, lots of great information here. These ladies are doing a webinar coming up on risk mitigation as well, using this continuum of care screener. I've got tons and tons of links to resources that we talked about in the show notes for this episode, including that webinar. So you're going to want to go to behavioralobservations.com and look for session 152. And you can get all the links that we talk about in this particular episode. So because this episode is pretty substantial, I'm going to limit the opening comments here. The one thing I do want to mention before we get to the episode itself is that this episode is brought to you with support from the 2021 Virginia Association for Behavior Analysis Conference. This year's conference will be, let's see, I got this wrong the last time I mentioned it. I believe it's the 16th and 17th of April. And this will be a safe and socially distanced in-person event as well as available online. So don't worry if you're not local to the Virginia area. If you do sign up, use the promo code GOMBU and save at checkout. Just go to virginiaaba.org for the details. We're also brought to you by HRIC Recruiting. Barb Voss has been placing BCBAs in positions throughout the U.S. for about a decade and has been in the business more generally for over 30 years. So when you work with HRIC, you work directly with Barb. There's no middleman. You're getting personalized services. So if you're about to graduate, you're looking for a change of pace, or if you just want to know if the grass really is greener on the other side, head over to hricolorado.com and schedule a confidential chat right away. We also talked about the Whoop strap in this episode, so I figured I'd mention it here. I've been wearing the Whoop strap for, a couple of months now, and it is, I don't know if I would, it's kind of a first world problem when I was about to say I can't live without it. I don't mean that literally, but it is fun to have, and I love getting the data on my sleep and my energy expenditure and calorie burn and everything else. It's just a ton of fun to have. It's really helped me kind of dial in certain practices to optimize sleep and wellness and things like that. So if you want to learn more about the Whoop strap, go to behavioralobservations.com/Whoop. We also have a Facebook group that I put together called Behavior Analysts Who Whoop. Again, you can get the links to all these things in the show notes for session 152. Last but not least, if you haven't already, consider joining the Behavioral Observations Patreon membership. Patrons get early access to podcasts, including ad-free podcasts. You don't have to hear me talk about this stuff. We just get right to the episode. There's bonus materials and bonus podcasts. There's a lot of content that's not on the public feed. There's discounts for CEU events, including those from FTF, Behavioral Consulting, and other continuing ed purveyors. We do occasional Zoom hangouts with former guests where members can ask guests questions directly. And lots more. So go to patreon.com/behavioral observations to learn more about that. All right, I think that's it for opening comments. So without any further delay, let's get to this thought-provoking and informative conversation about COVID-19 risk mitigation.
Welcome to the Behavioral Observations Podcast, stimulating talk for today's behavior analysts. Now, here's your host, Matt Sikoria.
All right, I am excited to be joined by not one, not two, not three, but 5 guests. I've got a whole panel here today talking about the continuum of care screening and all sorts of COVID-19 risk mitigation stuff. Lots of really topical things to talk about today. And because we have such a large group, I'm going to forego the usual introductions and just kind of let folks introduce themselves, and we'll just kind of go around the Zoom Brady Bunch square here. So welcome, everyone. And let's see, who wants to introduce themselves first?
Matt, I'll go first. Thank you for hosting up this group. My name is Zahra Hajiaghamohseni. I've been privileged and honored to be a previous guest talking about fieldwork supervision. I'm still in Charleston, South Carolina, and have a small group practice. Just rotated off my executive board for the state chapter at the end of November, and I'm still working on disseminating fieldwork supervisor resources and supports, and I'm excited to share with anyone who's interested. I am going to be doing a workshop at ABAI in May on improving your fieldwork supervision skills with my good colleague and friend Mika McCammon from University of South Carolina. So that's kind of where I am right now, and among COVID still.
Hi, Matt. I'm Jennifer Sweeny. Thanks for having us today. I'm pretty excited. I am coming here from Ohio. I own a practice in Northeast Ohio called Solutions Behavioral Consulting, and I'm the president for the Ohio Association for Behavior Analysis.
Hi, Matt. I'm Mary Caruso-Anderson, and I am past president of DC ABA. Happy to be here. And I am in the DC Baltimore area. I recently transitioned out of academia and now work for Intercare Therapy, which is a family-owned company doing in-home services.
Hey, everyone. I'm Sarah Duarte. I am out of Arizona. Right now, I'm working as a Chief Development Officer, and I'm also serving on the board, the Arizona Board of Behavior Analysis, as Outreach Committee Chair and Marketing Committee Chair. Super excited to be here.
Hi, Matt. Thanks for having us. I'm Christy Evanko, and I am out of Virginia. I own a company called Snowflakes ABA, which really just allows me to consult with a lot of different places now. But I'm also the administrative director for the Virginia Association for Behavior Analysis, which is very exciting. I also have some other exciting news, if you don't mind me sharing. Some of the people I can see you're excited. Some of the people in this group and a bunch of other people really have been getting together to do this sort of surprise, exciting news, which is the brainchild of Elizabeth Drago, who's at NISABA. And what we did was we worked with the National Day Archives to launch World Behavior Analysis Day. So World Behavior Analysis Day is coming to you very soon. Actually, it'll be March 20th, which is Skinner's birthday. And we've been very excited to work on it. People from APPA, ABAI, BACB, the Skinner Foundation, and then a bunch of the different state orgs have gotten together for that. So hopefully people will be seeing more about that. We also have a website called behavioranalysisday.com.
Behavioranalysisday.com. Well, congratulations for putting that together. From what we were chatting about just moments ago, it seems like there's lots of competition to have your international day. And so it's really cool that behavior analysis is going to be represented amongst things like Sibling Day and International Podcasting Day and things like that. So, yeah, that's definitely cool. So mark your calendars for March 20th. And can you just name that website again one more time, please?
Sure. It's behavioranalysisday.com.
Excellent. I'll have that in the show notes for folks who want to look that up. So, all
right.
Matt,
I was going to jump in and just add in before we get into the actual conversation. We wanted to make sure your listeners first of all, this is a plug for please join your state association or renew your annual membership. This particular cohort, the 5 of us, came together from an informal state chapter leadership collaborative that meets routinely offline to support each other with resources, so that we have unified membership response across the country for those more practical day-to-day issues that are more difficult for our parent organizations to get at, like when it's like acute and frequently. And one of the things was the 5 of us volunteered to form an ad hoc committee off of that, because we realized in 2020 there was so much information and confusion for membership across the country in the practice due to the, I would say, social political polarization. There was a lot of information and confusion about where to get good information on what to do next. So we all were getting questions then from our respective memberships through our executive board roles. And we the 5 of us agreed to, let's just take this on as a group and share resources and start talking about risk mitigation immediately to get resources out and start developing things. And we did a webinar last March that was the permanent product of that initial beta that we did through that committee. And then we've continued to document this process because the 5 of us are committed to getting out and more information and resources throughout the course of this pandemic, because it's clearly going to be around longer. But we wanted that to contextualize that for listeners, how the 5 of us originally came to be with you today on this podcast.
Awesome. Thank you for that piece of background. And I guess to further some background information for the listeners, so we're going to be talking about risk mitigation. And, as an official term, that's kind of a new one to me. The words themselves seem to make sense, seem self-explanatory, reducing risk. But before we get into the nuts and bolts of what you guys have produced here, let's talk about the concept of risk mitigation more generally, so the listeners and myself included have a more context to place this discussion in. So when you guys are talking about risk mitigation, what exactly do you mean?
Yeah, I'll take that question. So risk mitigation is, at its very simplest as an explanation, is identifying potential risks and taking action to reduce exposure to a potential risk. So let's just look at something that each of us do every day. We put on a seatbelt because of the risk of loss of life. So, or if you're in an ABA clinic and you have bookshelves and you have clients that may climb on bookshelves, you may bolt the bookshelf to the wall to reduce the risk of harm to the child. So that's at the core of what it is. Now, bigger picture to what we're going to be getting into in just a moment is we're right now in practice in the ABA side of practice side of ABA, we're ultimately right now attempting, each of us daily, to avoid loss of client services. And the risks that we're all continuing to do and deal with in practice that it's pretty clear now based on the data and the information for 2021 and going into 2022 ahead of getting that herd immunity is COVID-2, SARS, COVID-2, COVID-19, and the mutations that may occur. So right now the UK variant and South African variants are on their way over, and any future mutations. So that is the known risk literally that we're here to talk about is COVID-2, and it's transmitted through close contact of an infected person through transfer of respiratory droplets or aerosols that enter in through your eyes, nose, or mouth of an uninfected host. So there's some things here I want to just sort of, like you said, lay out, so the terms are very clear. The virus is not going to discriminate against age, profession, race, gender, client, consumer, provider, background. It's literally just looking for an uninfected host. So that's important information, I think, from the science side of it, because none of us were epidemiologists when we had to quickly pivot. And it was overwhelming for, I'm sure, not only just the 5 of us, for every other person to say what is actually going on right now. And so now as 2020 unfolded, I used to be afraid, you guys, of touching my Amazon package until like August 1st. I was like, there's no way I'm touching that. So we got more information. And so now it's clear what we're trying to mitigate is that specific component. ABA at its core, we are close contact professionals baseline. That's a core feature of our occupation. We're typically around other human beings within 6 feet for more than 15 consecutive or total minutes in a 24-hour period. And that's what the center's CDC says close contact is for in relation to the viral transmission of COVID-2.
And so that's why you wouldn't get it at like the grocery store, right? Because you're circulating around hypothetically, right? Whereas, the prolonged contact with consumers of ABA services, is the complete opposite of that.
I would say you still, in fairness to that question, in case there's an epidemiologist listening or someone who does risk mitigation all the time, you probably still can get it at the grocery store. The likelihood of you getting it through the nature of our job is, I would say the probability is like a lot higher.
Yeah.
That's
kind of, that's my, totally what I was getting.
You're going to get like a comment on your Facebook feed. Zahra was actually
you actually can get it at the grocery store, guys.
Yeah,
Come
exactly.
on.
Yeah. So in the absence
talking about probabilities, people.
Yeah, that's right. So in the absence of herd immunity, Matt, which is where we're trying to get to right now, and easily accessible pharmaceutical interventions, the number one most effective non-pharmaceutical intervention is literally physical distance. And we understand that now through 2020. There was a lot of information, a lot of confusion, but that literally breaks the transmission cycle. Like if you're far apart from someone, it can't jump and find a new uninfected host. So let's think about that for a second. If you're an ABA provider at baseline, like the nature of your profession, you're a massage therapist, you work in a salon, anything that relates to your job that's close contact, including what we do at baseline, means that it's almost incompatible at baseline that we can effectively break that transmission cycle, right? So like anyone who does hair, nail, makeup, actors, Hollywood actors, NBA sports teams, right? Look what the NBA was able to do over the summer. But there is so much involved in that aspect. If that is the core feature of your job, is to be close to another human being in relation to COVID too. So when we're talking about risk mitigation and ABA, that just sort of sets the tone for what we're about to get into. And Mary is going to give us a little bit more of like that broader picture of what's been going on, but that just sort of sets the stage for specific clarity and how this is a risk to us specifically.
Are you looking for a new job, but you're overwhelmed with all the emails that you're getting from various ABA agencies? What if there was someone who was in your corner and could help you find the perfect job placement? Well, that person exists. Barbara Voss has been working as a recruiter for over 30 years, and her company, HRIC, specializes in placing BCBAs in permanent full-time positions throughout the United States. Barbara has been placing BCBAs since 2011, so she knows our business, and she offers personalized service to any BCBA looking for a new position. She also helps companies looking to hire BCBAs too. Here are just some of the things Barbara can help you with. She can provide information about salary ranges in different markets across the country. She can help you write your resume. She can coordinate and prepare you for the interview process, and even help negotiate the right salary for you. And best of all, there are no charges to any candidate for all of these services. When you're ready to make a change and want to work with someone who will listen to you and understand what you need in a new position, contact Barbara at HRIC. To schedule a confidential discussion, head over to hricolorado.com. Again, that's hricolorado.com, and hit the contact button to connect with Barbara. You won't be disappointed.
Sure. So I do want to build on what Zahra said and just kind of take a minute to recall how things were at the beginning of the pandemic, because I think now that we've adjusted to life with COVID, we've forgotten the enormity of the challenges that we were faced with as a field. ABA has been around in full force since the late 1950s, so we've been here a while, but not as long as maybe some other fields. But in our field's lifetime, we've never faced a challenge like the one that's been presented by COVID-19. It wasn't just a subset of practitioners or a given geographical region that had to respond to this crisis. Our entire field had to pivot, and the entire field had to pivot without the benefit of knowledge of how to deal with this. So we didn't have prior experience on how to handle such a global event. And we didn't have the benefit of cohesive leadership because conditions were different from state to state. So there was a lot of confusion at the beginning. For the past year, all our social institutions and businesses have experienced massive disruptions and have had to adapt. But I think that several factors complicate how ABA practitioners have and will continue to navigate the pandemic. First, For example, a majority of practitioners of ABA provide services to the most vulnerable individuals in our society, and we provide those services across a lot of different settings. So it's a really complicated task that we're looking at. Additionally, most BCBAs don't receive any kind of systematic training in preparing for or lessening the effects of threats faced by ABA organizations, during their coursework, during their training, their fieldwork supervision. Mostly training in this area occurs by virtue of the students' unique clinical experiences and as they navigate their clinical cases and employee issues throughout their career. So practitioners improve their awareness of business risk by experiencing problems and dealing with them, or by watching and other colleagues deal with them, consulting with those colleagues who are experiencing their own professional risks. So risk mitigation training in ABA occurs primarily through experience. And unfortunately, because we are a relatively young field and we're a rapidly expanding field, the majority of practitioners in our field are at the beginning stages of their career. So they're young career practitioners. And so they don't have that career experience that more seasoned practitioners would have in mitigating risk. And then to add to that, the risks presented by COVID are completely different from the risks that we deal with on a day-to-day basis in our practices. And those risks are changing and evolving as the pandemic continues to unfold from that acute phase to the long-term outlook. So during the acute phase, we were caught unaware in those initial months of the pandemic. Like, the disruptions were so extensive. We didn't know much about the virus or how it was transmitted or its course or outcomes. There was little access to testing, medical services. We were fighting over PPE. So, there wasn't much protective equipment or cleaning supplies, especially here in the United States. And there was limited professional guidance for practitioners. So, I remember for the first month or so, it was difficult to even determine if you were considered an essential service, right? So we had a lot of variability. Some ABA businesses completely shut down and others kept running business as usual. So there was a lot of variability in that initial response, especially before the codes for telehealth were consistently approved. So at the beginning of the pandemic, we had this situation where we were faced with an unparalleled challenge for which we had little prior training and few resources to help navigate. Now, that did change, and it changed quickly, especially within our field. So we had profession-specific resources that were developed by the BACB and APBA and CASP, to name a few. And much of this information was compiled and shared, like we mentioned earlier, through our state ABA organizations, because that was a good way for us to quickly and widely disseminate a range of information that was pertinent to clinical practice to a large group of practitioners. And one thing that we saw as a group was that practitioners were really struggling with the range and amount of information that they needed to consider to make decisions about if and how to continue services. And really, this wasn't about making one decision to keep a business open or to close it down. It was about making this decision repeatedly over and over regarding the correct dosage and intensity of services, from none to telehealth to hybrid to in-person services for each client within any given organization, and then managing the risks to both the family and the employees associated with those individual decisions. And so that was what really struck us, and what was really important to us was that this isn't a business-wide decision. There are business-wide considerations, but what's really important is that each business has to approach that family treatment team dyad from that risk perspective, taking all these other factors into consideration. So now we've kind of moved past the acute phase of the pandemic, and we're in more of a chronic phase, and we're going to need to continually revisit these decisions as conditions change. So the ongoing impact and the stages of recovery are really expected to last until about early 2024. And we're seeing that recovery is not like a linear process, right? So over the summer of 2020, we saw some businesses open up only to have to close again in the fall. And we expect that the vaccine will help in return to normalcy, but the rollout's been slow. There's new mutations, as Zahra mentioned, that may lessen vaccine efficacy. So we have some challenges that we're facing. And we wanted to develop a resource that would call attention to all these pertinent variables that practitioners were going to need to consider, not only in making those decisions during the acute phase of the pandemic, but then in monitoring that risk on an ongoing basis and revisiting those decisions as conditions changed. And making that decision to not provide, pull back services for families. So we viewed these factors as kind of a funnel with wide-ranging considerations like national, regional, or state-specific mandates, down to organizational factors that were going to influence service delivery for all the families in that organization, and then down funneling further to the needs and the status of the family treatment team unit. And so Zahra, Jen, Sarah, and Christy are going to kind of take us through that funnel, through those different sections of the screener to kind of illustrate the decision-making process.
Hey everybody, I want to take a quick break here and tell you about the upcoming Virginia Association for Behavior Analysis Conference. It will be held both online and as a safe and socially distanced in-person event. Remember those? This year's event will feature keynote addresses by Drs. Nasia Cirencioni-Ulizi, who was on the most recent Behavioral Observations podcast episode. And that episode got a lot of great feedback, and so she's giving a talk on leadership that she spoke briefly about in our interview. There's also a keynote by Dr. TV Joe Lang. There'll be a whole host of other great speakers as well, and I'll be hosting an audience Q&A event as well, so lots of good stuff. So I hope you go check it out. Again, it's on April 16th and 17th. If you do decide to register, I would like you to use the promo code GOMBU, all in uppercase. That's GOMBU. MBU stands for Mary Baldwin University, one of the conference sponsors. So again, go check out the Virginia Association for Behavior Analysis annual conference. You can find all the links to that in the show notes for this episode. So you can go to behavioralobservations.com and check out session 152, and all the links will be there. So I think that's it. So let's get back to this conversation on COVID-19 risk mitigation. So with regard to, so you guys put together a tool to help walk people through the ins and outs of how to take in all these various sources of information, both from the information that's coming at them from a media perspective and from a public health perspective, as well as the information from what they know about their client base as well as their staff and things like that. And I think it'll be fun kind of getting into the particulars of that. Before we do that, I'm curious, are you guys aware of this sort of tool being developed, being deployed in other healthcare industries? In other words, is there sort of a continuum of care screener that it's being used in dental offices or physical therapy clinics or do we know of other people doing this sort of, legwork, if you will, or risk mitigation, I guess, to use the term of the podcast?
Matt, let me ask, do you just specifically, do you mean relative to COVID-19 or just in general as part of how they get trained in their profession, like through their graduate?
Yeah. Well, I was thinking relative to COVID-19, but that's the other point you raise is also an interesting question as well.
Yeah, I mean, I think that our field is in a unique position because we, like Zahra said earlier, we are very close contact and we're in homes. And so I think risk mitigation for some of these other practices, a lot of times they can and do move to telehealth if they're speech. With dentists, my kid goes to the orthodontist and they have their specific protocols that they do and they spread people out and they've adjusted. But I think it's a little bit less intensive for them in terms of, he goes once every 6 months. Whereas, we're seeing children on a continual basis. Yeah. Sometimes they have risk factors in themselves. So I think our field has really had to make more of an adjustment.
Because the dosage of contact is considerably higher. Yeah. Okay.
Yeah.
That's a great point.
I think also too, because, and I, in the course of this and with my work with the state, I was on a bunch of calls with the Department of Health and listened to how they kind of manage these things and talked about dentists and other offices. And I think because they're so established too, these types of protocols might already be there, but also laws that came into place, like they would say, oh, the elective surgeries are no longer, you can't have elective surgery anymore. And now you can have elective surgery because government is thinking about their professions. Whereas we're still in the place where government's not really thinking about our profession. And so we're kind of left to decide, does this apply to me? Or, am I, that's what, like Zahra said, am I an essential worker? That took us a long time to learn that because never anywhere did it say behavior analysts are essential workers. But it does say things like doctors are essential workers. Dentists, not so much unless they're doing, surgery immediately, or I don't know, dentists are going to yell at me. But I just think it's part of our profession that made it unique. So I too haven't really heard of anything like that.
Okay. Very, very good.
Matt,
right.
can I do a quick plug for you? Because your podcast has given me a wealth of resources, and I want to echo a previous guest you had who brought up Apollo Zero by Dr. Nicholas Christakis. So that was a publication that came out at the end of November, and I heard that on the podcast, and I went and pulled it while I was finalizing my lit review for our manuscript. And oh my gosh, that I recommend that for anyone who's listening. It's on Audible. You can, get it as a hard copy. I read through that book and it has changed my understanding of what's happening right now, what we're actually going through right now. It came out the end of October, and it's really how now as the business owner and just as a person going through this in the world right now who's alive experiencing this, he did a beautiful job describing pandemic history. It's a neutral place devoid of socio-political polarization where he's just literally describing goodness. Yes, right. Pandemic history. He talks about how we responded, what we did. He talks about the closing of schools, the vaccine, anxieties around vaccine, how quickly it was produced. And he talks about some of these things in relation to previous pandemic responses from 1918, 1956. And so I think that's a really good resource for anyone who wants like a neutral spot. Like that helped me so much going back to the introduction of our manuscript and coordinating with Mary and really like talking about the timeline and the shift and focus on get comfortable because this is not going away in 2021. And it was a little depressing when I was reading that over Christmas. I was digesting it. And I was actually listening to your end of year ABA track. And I was thinking the year ahead, you're asking like, what are we going to do in 2021? And I was like, well, Matt, I want to tell you
about the same.
Yeah, we'll be doing more of what you're doing this year. So like, I just think that's a great resource for anybody who wants a neutral reference, and it's great on Audible. It's 12 hours on Audible. So yeah, echo what a previous guest mentioned, but it's a really good resource.
Very cool. Very cool. Appreciate the tip there for the audience. All right. So let's get into the continuum of care screener. What are the, how did you guys conceptualize it? How was it developed? And let's talk about then what the constituent parts of it are and how people use it. So anyone can, who wants to grab that one? Or the first part. Hey, that's my 7-part question, right?
I love it. Okay, I'll take a stab at it. I'll go ahead. So the conceptualization of it, going, and by the way, your job is serious with Linda LeBlanc, and that has been so helpful. I really appreciate you guys talking about that on the podcast, because peer review, anyone who's gone through it, it stinks when you're like, oh, I didn't get accepted, or I got a lot of feedback, right? Nobody really wants to get critical feedback, really. But the purpose of peer review is to make the best possible product. So that is the core of what it should occur. When we were submitting this, and we've gone through peer review, we've gotten really positive feedback. Initially, we were like, well, hold on. We went back and we're like, actually, that person's right. That peer reviewer is right. We need to consider this at a different lens and a broader lens. So the peer review process, just again, a shout out for your JABA series, that's really helped shape the revisions from our initial beta of what we developed from that March 2020 webinar, where we really were focused on the acute shift. And the peer review process challenged us and said, hey, think about this broader, and think about additional elements that we hadn't thought about, because we were still trying to survive that initial shift to telehealth and not sure what was going on. So when we worked on coming back to the table and we were considering a technical submission, which we will be doing at this point, we reorganized and reshuffled it around to have, as Mary described, that linear approach where we would we're calling it a Part 1 administrative section, which touches on subsections of the federal, state, local, or country-specific, province-specific for our international colleagues that are practicing abroad. And then it gets down into Part 2, the clinical assessment. So it really is a funnel that this beta initially got shaped into a fully comprehensive document that would catch, probably, I would say, and you guys can jump in, the most obvious risks that would ultimately impact and increase the likelihood of abrupt loss of clinical client services. Because that's really what we're trying to do, is funnel in and identify known things that are going to come up over the course of this pandemic that is 2021 and into 2022, and go ahead and start thinking now. Because what you don't want to happen is you're like, I've got 30 days of payroll left, and then I got to close down. That's not so good, no. Especially now that we have more information. So anybody else have any thoughts on that? I just want to make sure
Yeah, and I mean, just the fact that there's so many variables that practitioners need to consider in making these decisions, right? So the idea was to really call attention to all of these different factors that we need to pay attention to in order to make, an ethical and an effective decision about services in this context of this pandemic, which we've never dealt with before.
Exactly. And so the structure of it, I'll just go ahead, if you're okay with it, Matt, and start describing the segments of it. So when the tool itself is designed to start with what we would consider administrative leadership. Now that we've gone through a whole, basically 3/4 of 2020, there are a lot of people who took financial hardships. I know for my company, and I'm comfortable disclosing this, I was at a 50% loss from 2019 on my profit and loss sheet. So I've had colleagues who've been, messaging me, they're losing $100,000 a month due to COVID-related disruptions. So now we know that's a known variable that will ultimately it's a known risk now in practice for us. So the first section should be completed by people who are basically in charge of making decisions about the actual business and the operation of the business. And that will lead into Part 2, which is that clinical individual team assessment. And the first part, what we're trying to have people do in this section, the bigger picture outcome, is the agency owner. And we want to make sure we clarify, you can be a sole provider like Matt Zakoria, LLC. has 15 clients, or you can be Snowflake LLC in Virginia with 50 client or 50 employees. Doesn't matter the size or your volume. So whether you're yourself or you have multiple people under you in your workforce in a huge practice, that we're asking you to clearly go through this through the guiding set of questions that are administrative in nature that may quickly close your business down and result in abrupt loss of service. So these questions and prompts are designed to evoke like that critical thinking at that larger picture level. And it starts with federal and state or country specific mandates. And the first one is really just pretty off the bat, really clear. Are any mandates, federal, local, state level, that would prevent non-emergency or non-essential services? And we replicated that off what we initially saw. At this point, what we've seen consistently is that ABA providers, as Christy mentioned in relation to, we're not even really acknowledged or referenced right now by our state governments when there's these sorts of things happen. But it seems like we've been able to sneak in under the essential provision. So that seems to be pretty clearly well established. Is anyone aware of a state that wasn't able to practice under that? Resume under an essential? Anybody?
No. And it seems like we're getting in for the vaccine under that healthcare category as well. But that, could be variable from state to state as well.
Yeah. So the important thing, though, to consider is that beyond a federal mandate, you have to also be really aware of the state you're practicing in. And I'll give a very practical example. The face masks, which are the number 2 way right now, non-pharmaceutical intervention, and Dr. Christakis talks about this. If you can't be 6 feet away from someone, then please cover your face, because that's protecting them and theirs is protecting you. It's a physical block for the virus from getting into your nasal and oral passages. But that should be really clearly like a decision that, in my opinion, and I'm okay saying this just as Zahra talking for herself, it should be implemented in all 50 states. However, only 37 states have a required face mandate, and it's starting as young as age 3. Now, Sarah and I both work in states. She's in Arizona, I'm in South Carolina, that do not have state level required mandates, and my other colleagues do. So I'll give you just a quick anecdote. I have to apologize sometimes, Matt, for asking people to please place a face mask on when I'm coming into their home. I'm so sorry to have to ask you to do this. I'll kind of scrunch down. I'm so sorry. But when we're having a conversation, I need you to cover your mouth when I'm this close to you, talking to you about what I'm about to do with your child. But I'm apologizing for it. Whereas I don't know if Jen, Mary, or Christy has the same level of even consideration when they're even having to go about their workday.
Yeah, I mean, in DC, it is so commonplace. People are wearing their masks when they're walking around outside. They're very conscious of this and they're very protective. So it's a much different context for sure.
Yeah, I mean, I can see being in someone's home being a different level of comfort with not having your mask on versus being in a clinic. You can make, but I think the perhaps the larger point is maybe some sort of, regardless of what the state policy might be, some administrative policy about, when our staff are in your house, yes, it sucks, but you have to kind of put your mask on when we're in there giving services, or we're coming into the same room to have some sort of debrief or something like that.
Yeah. Exactly. So that the purpose of that main question is to draw people's attention to any state, local, or specific mandates that will impact organizational behavior. So just to make you draw in and key in, and know there is still a high degree of variability. And in New York, I think you have to wear a face mask at age 3. I think Virginia is age 5. So in some states, it's 12. High degrees of variability.
Sure.
So then it funnels you into, once you've identified what those could be, into where more the meat of the administrative section will focus is the organizational climate. And this is, I would consider, a very linear process as well, where first we're going to guide people to consider workplace safety considerations. So are there organizational barriers for how you baseline or set up? So I'm home-based. I travel to people. Some people may be clinic-based, or a mix of that, that you need to be aware of for OSHA. Department of Health and Environmental Control, DHEC, or also you need to be very familiar with CDC. And the answer, I think I'll go ahead and clearly say, is yes. You need to be aware. There's a lot of things you need to do and consider in relation, whether you're sole owner, agency owners. We really have to consider now, because of the nature of our work was baseline close contact, that by that specific aspect, you have to now go look at OSHA, CDC, and DHEC. And so some examples that we've probably seen more prevalent in schools that you may need to consider are partitions, cleaning cycles, barriers, PPE, buying masks, thermometers, any sort of, also, this was a big one. And I, by the way, I caught this at the end, but you have to also be ready as a workforce or organization to comply with your local DHEC's quarantine requests or isolation periods. And that means loss of money. And so that's an item, a derivative item of you following your OSHA or DHEC. You need a plan for loss of money for quarantine or isolation periods. Here you go, Matt. I had a little note for you. Plug for Whoop. I am whooping these days, and yes, it's because you're a podcast. I actually purchased a Whoop for my staff after you had your podcast. And I think anyone listening, I want to encourage people to go to Matt's website, and he has a Whoop tab on his website, and it'll direct you to where you need to go. They have very compelling preliminary data on the use of this technology to for the respiratory rate feedback to identify a subclinical symptom associated with COVID. So what's happening is that's really good because that helps people maybe make decisions on about who maybe needs to go do face-to-face on those days. But there's really great peer-reviewed article on that that you can go to the Whoop website through Matt's homepage. But that was something I built into like one of my things I was going to do as part of workplace safety. We've seen college sports teams actually start doing this, and certain workforces are already placing this sort of technology on to track that sort of information to help them make decisions for workplace safety. But again, my point is identifying what you're going to have to do to make your work environment safe and what those things literally are going to be. Another side note I wanted to point out here, which I think can be overmissed, if you're someone like me in my situation where I travel to individuals in their environment, you have to also, if you're the owner of the company, I have a responsibility to know where else my child has been. Like if they've been at childcare centers or schools, I have a responsibility if I'm sending my staff into their home to know where that child has just come from, and if that location is following CDC and OSHA requirements. A very real example that I'm dealing with right now is I have a child who's in a childcare center that is not governed by the Department of Education. They are not requiring masks. They're not doing fever checks. They're not doing curbside drop off and pick off. Then I have a staff going to the home immediately after the child gets picked up and brought home to do service. That is a huge risk to my staff member right there because of that environment the child's coming from. So that's something you have to consider if you're doing something with a child who's coming from other service environments. You need to be aware of where they, that would be more than 15 minutes and close group contact with other people. That's important because you have to mitigate that for your individual potential employee. Once you've identified all that, Matt, then we're going to ask you a series of questions in relation to financial considerations. Bottom line here is we're going to go ahead and tell everyone this. You need to have a 2021-2022 COVID-specific operating budget to include all of these workplace requirements. Essentially what we're asking you, can you keep your lights on, and for how long in the absence of steady funding streams, can you pay out your normal overhead? So if you have a clinic, rent, COVID-related overhead, and any other things that may occur in relation to loss of income and paying people out for things that would be qualifying under the CARES Act for COVID-related sick leave. You need to identify all of these things and say, how long can I keep my lights on if I'm making this much loss, if we're hitting this much loss? You need to determine that objective threshold now because we know it's a risk. Everyone here, all the 5 of us have lost money at our practices. Matt, I know you've been really gracious about sharing. Yeah, exactly.
Yeah, we'll just call it 6 for 6.
6 for 6. I love that. Yeah, we've all had that. And so you need to go ahead at that point. It's strategically just identify, okay, how am I going to make my COVID-19 budget in lieu of all of these things? Because what happens is, like that initial example, you realize I've only got 2 weeks of payroll left, and then I have to close down. That that's not good for a lot of reasons, and that's especially not good for your consumer. So those are things we guide you to consider. And one other side note I wanted to say, because Mary, I think you mentioned it in your in your beautiful introduction to this topic, is you also need to be really familiar with your state's DHEC COVID data that they're releasing. You need to be in touch with that. So if you're a practice manager or you may not be in the field, like actually the one in the field delivering the service, you still need to consider that the state's decisions, and I'll use my state, I don't know if Sarah wants to use Arizona as an example, they may be influenced by other contingencies, and leaving the decisions to make how you operate as a business up to the individual business owner. And you as an individual business owner could be easily swayed by other contingencies and cut corners on how and what you're doing. So there's a responsibility you have to delineate, okay, there's a legal requirement or state requirement, and then there's the ethics behind best practices for this management. And for South Carolina in December and early January, Matt, we had a positivity rate for a few days about 33%. And so my sister who lives in Maryland, she called me around the same time and was freaking out. And she said, oh my God, we just hit 10%. Everybody's closing down and everyone's pulling back. And it gave me a moment to pause and think, Matt, because I was like, then my team shouldn't even be in the field. Right? I mean, sure. Community-wide transmission is out of control. So the ethics of that, but I had to pause and think. I was like, but then I'll lose money. And I'm being very honest right now, because then I thought the business owner of me said, well, how can you do that? People won't, and that's what I'm talking about. You have to think about these things now, because we know it's probably going to continue happening in waves, like the ups and downs. And I don't know if anybody else wants to talk about that particular topic. That's a really gray one, like when to pull your teams back out. When are you no longer comfortable with that data? And the CDC has really good information for businesses that's reopening, and that staging criteria that they put out in relation to markers that show community-wide transmission is going down. And a lot of schools use that in their back to school safe, or back, I don't know what the name, anyone who has a kid can help me. Is it back to school safely or opening schools safely plans? Does anyone, Matt?
I don't know.
That sounds good.
Okay, all right, something like
schools
that.
have opened and closed so many times in my neck of the woods. I kind of, it's like every time I get an email from the school district, they kind of, I kind of glass over a little bit. But can I just, I want to just pause here for a second and just, I do admire the candor of going into the detail and talking about the financial aspect of this. I think it's I don't know, that it's a very real thing, and we all would love to say we're going to make decisions, by the book, et cetera, et cetera. But I think we'd be also fooling ourselves to not be aware of the competing contingencies that are out there, and it's not just a something, it's not just a mercenary thing. It's that, if you're not generating revenue, I don't have any direct employees, but if I did, I'd be frightened for them more so than for my, if you have people counting on you for a paycheck, that's an incredible burden. And I've got friends and colleagues who had to furlough their whole staff and, had to, and they're starting back from square one right now. And so it is a big giant mess. So I just want to acknowledge and compliment you guys on being, just super candid with that aspect of those things that we don't like to really talk about in polite society, or at least I know. I was raised to that it was impolite to talk about these things in public, but it's definitely something that needs, it's a conversation, or an aspect of this conversation that is certainly necessary to have. So
I think that was one thing we really tried to consider the whole time, was who was going to be making each of these decisions, and who did this affect. And when we were developing the tool, we were really concerned about that ethics part of it, and we have this obligation to our board and to our ethics code, but then as a business owner, they have an obligation to just keep the doors open and to really make sure that their client doesn't lose services and their employees have a place to go to that's safe. So I think in the very beginning, when we started working on this tool, we were just like inundated with so much information, and just we were all running our own companies and trying to think about this and trying to learn and be experts on the CDC and what their guidelines were. And I mean, I think that took me, it was like a full-time job just keeping up with what the CDC had to say and what the guidelines were to keep my employees safe. And could we keep the doors open? Were we even allowed to practice? All while kind of thinking about the ethics side of it. So yeah, that was always the first thought every time we went back to the tool and continued to revise it over and over. That was always what we kept coming back to, was how do we really help the BCBA, who's a member of the team, but not at the top. What information do they need, and what does the top need? And so we really tried to, and if you're a solo practitioner, you need it all. So we were trying to really make the tool as easy as possible, and just give them this framework to just like build off of, so they can gather all the information that could be so unique to each and every person.
I was going to say, and I think too, we really tried to stress the importance of a collaborative approach, administrative, clinical, organizational, operations. So all these pieces of the company, whether they're one person or multiple people, need to be involved in this decision-making process.
Matt, I was going to say, I almost went and worked as a barista and put my job as an ABA agency. Jen, I think I just had PTSD listening to you to describe all of 2020 for me.
But I think too, we have a little bit of experience with this in that the way the ethics code is written for BCBAs is there are a lot of places where they don't match, or like if you follow Rule 4, then you're not following Rule 6. And I think we just need to know, well, that's because there's so many options out there, and there's so many other things happening in the environment that you need to look at all of those. And yeah, maybe you're going to have to break Rule 4 to follow Rule 6. And I think that's what we tried to do here too with the screeners, to help people sort of get down to that and ask all of the questions.
It's like the BACB exam. Which answer is the best?
The best.
Out of the multiple correct potential answers. All right, folks, this is the last commercial break of the episode, and it's all about the Behavioral Observations Patreon group. If you want an ad-free podcast feed, so you don't have to listen to me do what I'm doing right now, go to patreon.com/behavioral observations. You can get your own ad-free podcast feed where after a brief introduction, we basically get right to the podcast interview. Some of them I've been playing around with. I just cue the intro music and start the interview without any opening comments. I know, pretty scary, huh? But yeah, it's I'm having a lot of fun with it. We'll do some patron hangouts. In fact, I'm due to schedule one sometime soon. I need to get one on the calendar, and that's where I bring back a guest, and the patrons get to ask the guests questions directly. It's usually a fun time, and I also release those as podcast episodes that are members only. So I've been actually going back through some of the members only events that I've done over the years, and picking a few to release as private podcasts for patrons. There's some other cool benefits as well. If you are an early adopter and above tier patron, you get some pretty steep discounts in CEs, not just for the behavioral observation CEs that I sell, but also the folks over at FTF have generously offered a 20% discount to all their on-demand courses. And as an aside, I just finished the 10-hour practical functional assessment and skills-based treatment course, and coming from someone who's read a lot about it, who's talked to Greg Hanley personally about these things quite a bit, and a lot more, The courses were awesome, and I learned a ton, and that's coming from a baseline level of knowledge that is that I previously thought was pretty high, but there's a lot more to learn apparently. It's really, really good stuff, and I think if you think through all the three major courses that they offer, taking 20% off each one of those, it adds up to quite a bit, and it can almost be revenue neutral as it relates to the Patreon membership. So just something to consider. If you want to learn more about that, you can go to patreon.com/behavioral observations, or you can go to behavioralobservations.com and just hit the Patreon tab at the top. All right, so that's all I have about that. So let's finish this conversation about COVID-19 risk mitigation. So let me ask you this. I know, like, just reading the draft paper that you guys sent me, that you're trying to, through interviews, get some really quite frankly personal information on both your clients and certainly the staff members working with them. Tell me about that experience. I mean, that did in kind of beta testing this, did you guys get any pushback? Like I live in a state where there's the state motto is live free or die, right? And so I can imagine a lot of people saying, like, that's none of your business, and did you experience any of that kind of pushback with trying to collect this information? And I think it has different ramifications, because I think it's equally valid, not just from the family perspective of the client, but also the staff that work for you. There's probably some, there's a, I guess in an ideal world, there's a right to privacy for people to kind of do, conduct themselves in their own, on their off hours in any way they like, and so forth. So can you guys talk about some of those challenges?
Yeah. So we're going to talk a little bit about part 2 and the clinical assessment portion of that. But one thing I was going to say about it is, the BCBAs who are working with with each of their clients, they know their client best. So yes, this is a lot of really specific information, a lot of personal questions, but they can pick and choose which ones they're going to ask. So, and the parent can definitely pick and choose which ones they're going to answer. I mean, I think that there's we talk about making sure that we gain consent and that the parent is open to answering these questions. And then that BCBA kind of guides the conversation through that structured interview with a lot of guiding questions, open-ended answers. But in terms of like feedback that we got, I think we're going to talk about, I think that was Mary that was going to, or Christy's going to talk about our content, what people had to say about that. But just, I think more of what we heard back from people was, I don't know that we got a lot of pushback on not wanting to answer specific questions.
Okay.
No. Go ahead.
Good.
I did.
We did get a little bit. I mean, I think if we looked at the thing, there were a couple of things where they're like, wow, I don't think I'd asked this question. I think there were a couple of times in the data that it said, I don't think I'd asked this question. I don't think that asked that question. But I think the overwhelming feeling was, but you know what, the rest of the tool is fine. I don't actually need to ask that question because I have that answer. Or if I just leave out that question, that's okay. That doesn't mean that I can't get more information. And hot buttons for different people, I think, differ depending on your area. For some, it was the temperature checks and things like that, or some it was social behaviors, and it would just vary. So I think we dumped everything into it because we wanted you to be able to pick and choose, because we come from 5 different regions, very different regions, and we know that anybody who's going to use it is going to be in another different area as well. So you want to include everything, and then you're going to have to leave it up to the practitioner to decide what to add.
I do think that context matters too. And going back to what Zahra was talking about, if you have certain protocols that sort of contradict maybe what the state is or is not doing, having those conversations up front and just kind of getting everyone on the same page, like we're trying to do the best we can and you're part of that. So this isn't like us prescribing some dosage or a situation that we're going to pivot to exclusive of your inclusion in that. And so I think also the way you approach it is very important, because we know it's not lost on us that all of this was very emotionally charged for everyone. There were so many changes, so much happening that, we're gathering all this information, but it's not objective for most people. On paper, it looks like it, but when you have these discussions, it's a difficult time, and it was a difficult time. And so I think context and the approach really, and just kind of sharing the why behind all of this was really important and is important moving forward.
Yeah, I mean, ultimately gathering this information allows the treatment team with the family to decide the best course of action to meet the child or client's needs and the family needs. And so approaching it collaboratively like that, and kind of letting people know, we need this information. I'm sharing this information about myself because I'm part of this bubble, I think for us was really helpful.
Matt, I just also wanted to point out, I don't know if you guys remember this, but there was lawsuits employees were filing against their employers very quickly last summer for workplace negligence. Like you like in relation to, I caught COVID at work. I don't know if any of you guys saw those, like there was billboards, lawyers advertising to represent you as an employee, citing their workplace was unsafe, and they caught it from there. So I think there's a practical issue and I'll just be transparent that I can appreciate people's discomfort, and it's an uncomfortable thing to ask some of these questions, but I also think there is maybe some legal ramifications potentially if we're not asking certain questions now that, like, again, risk mitigation, we know more about COVID now than we did last year. So from the organizational level and kind of pivoting naturally back over to the screener, what I'll say, one thing for your workforce is as you go through, these are things I need, this is how much it's going to cost. And then it dumps into your bucket of, now that we're in 2021, now you need to think about COVID specific mitigation to help your employees be as safe as possible. So we talk about COVID-19 specific screening. You need to make sure there's some process that an employee or staff can let you know, hey, I'm high risk. I didn't want to have to disclose my personal medical history, but I'm going to get a note from my doctor, or I may get reinfected easily. So you need to be aware of that, because if you have too many high risk people, like I had a couple staff that were pregnant and I had to make some accommodations for them because we didn't know initially in 2020 enough about the impact of COVID on pregnancy. So you need to make sure you're asking those questions. You need to also now's an opportunity with 2021 rolling in and the COVID vaccines coming out. We were, I think all 5 of us able to get I've had both. I was able to access the vaccines for my company and get them out, but you should go ahead and start having these conversations, because that's the first line of defense right now without getting natural immunity through an actual exposure. And then some other questions, depending on where you live, are routine COVID testing routinely. Testing keeps everyone safer, and Dr. Christakis talks about this. If you can test, you should test. It's an act of public service for people, especially who can't get out there and test, because you're helping break the transmission cycle. So you have to consider, if you're DHEC, our DHEC has a free program called Be Positive, You're Negative. Remember, we're at 33%, Matt. And it's free, and anyone can get it. Matt, you can come over to South Carolina and get a free COVID test. And then more importantly, we also want to draw people's attention to this. I think this was overlooked initially. If you're putting your folks back in the field, you need to also make sure they're trained on PPE protocols. And not just through a sheet, but through actual BST. Let me watch you appropriately seal a face mask, a face shield, gloves, if that's part of your process, and how you take these off and sanitize. There's a lot of things people were not aware of that now it's clear. These are known risks, because when you touch your hands close to your face, that's a point of entry for the virus as well, outside of inhaling them in. And lastly, before I ask Jen to take over and discuss some of these more clinical considerations that'll be interesting to discuss, I wanted to say there was one thing that came out is you want to have a healthy workforce, because that ultimately avoids the abrupt loss of service to your client. And so it's important that you don't want to have like a call where a client's, hey, my RBT didn't show up. And then you're trying to get your RBT on the phone and you can't get them on, and it's like a week and they're just gone. They're gone completely. One of the things that came up for me was it's important, and I guess we'll call this anxiety or fear. Like, that's typically terms we don't talk about with our language, but I'm going to talk about them just very casually. It's important to have transparent conversations ongoing about how people may feel about COVID. As 2021 goes on, and like I will say this again openly, I've had COVID. I don't think any of the have any of you gotten COVID since I spoke to you last week? Okay. All right. So out of the 6 of us, I've had COVID. And I will say, Matt, it drastically changed. I got a COVID positive diagnosis in December, and it drastically changed everything about my perception on the psychological impact on the workforce. There was a lot of things that went on, but I will say that, like, for example, the loss of smell, people are saying, oh, it's a mild symptom. But if you're on day 30 and you can't smell or taste, and then you're seeing there's some people who can't smell or taste for months, at some point that may become a disability. There are some very real things that for me shifted drastically after having gone through COVID. In relation to putting myself in the field and thinking what it must be like for a doctor or nurse who's having to go in front line and has to deliver face-to-face. There's no other option to deliver that face-to-face care. So I think we need to be having conversations with and being very much in tune with people who've gotten COVID. They may have lingering symptoms. They may have a loved one abruptly die and didn't get to say goodbye. There are some very real psychological side effects that are described in Apollo's Arrow that are going to end up coming out of people who just didn't get to say goodbye or watch someone go through a severe episode of COVID-19. And then what may happen is, if we're not talking about and saying, well, we're using these protocols, like, here's how, yes, you feel this way. This is what we're doing at our job, at our agency, to help reduce your exposure. And ultimately, Matt, what I saw happen in the public school systems, some teachers just were like, it's too scary for me. I'm not going back this year, right? So there may be a point in the conversation, if you're having these proactive conversations, that someone may self-detect and say, this is too anxiety provoking for me. I can't do this right now. I need to go do something virtual completely because I'm not going to be able to give my client the best I can face to face. Or worst case scenarios, I just show up and don't even quit. I'm so freaked out. So we're missing those precursor behaviors by having those conversations where we can say, the person may lead and self-select out. So these are important aspects I think we need to be discussing. And we didn't really know how else to label them, Matt, other than say additional considerations, because we didn't want to say psychological impact or mental health. And I don't know if anyone else has any ideas, but I think Dr. Christakis captures this really well. There is a psychological impact of going through a pandemic as a country, and then how badly it impacted your household, whether your parents lost their jobs, you lost close family members, you have a lingering symptom that doesn't go away. And I don't know if anyone else wants to share if you have stories, but I think we have to be talking about it because we're trying to avoid abrupt loss of services for our clients ultimately.
Yeah, I mean, just in my own kind of anecdotal observations, I've seen, there's variability in how much people kind of worry about this. And not only from person to person, but within people too. I think that people were probably feeling pretty positive about the COVID. Where this was going in, say, like July and August, right, when cases were really down, and then everything started creeping up, and then massively accelerating thereafter. And so I think even within people, it can within someone, their attitudes and the resulting stress associated with it can certainly change.
And I think, Apollo's Arrow is just such a good resource, Matt. He talks about this actually as a phenomenon until it actually hits you. Like when you hear about it on social media, and even New York, everybody saw New York, right? I was freaked out. I couldn't get off the TV seeing what was going on in New York for like 30 days. That still did not change our behaviors in South Carolina, right? Like it was clear our numbers were creeping up, and he talks about this. It requires it to touch you immediately. Like when I got COVID, that's what I was sharing. It changed my perspective on what I'm asking my RBTs to do in the field, and actually start having conversations. Are you okay? Do you feel okay? And then people who've had positive COVID tests, are you feeling okay? What's your stress level? Are you worried about you're going to give it to your 3-year-old daughter, your husband? How are you, like literally talking that candidly and casually? But he talks about that in his book. In 2021, it's going to hit people a lot harder because the prevalence rate at the end of December was 15% had natural immunity. He talked about herd immunity is 65 to 70. So as those numbers creep up, then it becomes more local. And then you're like, oh, now I understand why wearing that mask was really important, and why someone like Zahra was screaming at me all summer to please put your mask on.
Put your dang mask on. So it's Apollo's Arrow.
Yes,
Okay,
it's
I'll
so
put a
good.
link to that.
He talks about this phenomenon, exactly what you described. He talks about it. And then this really segues you into like a beautiful graphic, and it says, hey, listen, in each of these sections, what variable did you identify and what is your mitigation strategy? And so for me, I'm going to be applying for the second round of PPP, the payroll protection program. I already know that. Or for you, it may be I'm going to stay linked into my unemployment system whenever I have to do isolation or quarantine protocols. The point is I know I have a plan for when this happens. I can respond versus react. So that kind of segues into these decisions then get funneled down into the clinical assessment, which I'm going to ask Jen to kind of lead us off into that more specific clinical screening.
All right.
So, I'll go quick through the clinical assessment portion of it. We really wanted to kind of make it as easy as possible for the BCBA to go through it. And like Sarah was mentioning, it's so important that the clinical assessment included the family, the child, and the whole caregiver team. So we really looked at caregiver as anyone who's really with the child. So that includes the treatment team. So the way the screener is outlined is the whole first section is all family and client. And then that same exact section just like repeats itself. So the BCBA is kind of going and asking those same questions about themselves and about the RBT team. And really what this does is it gives a place to document. So it can be ongoing. It could be the first time you're meeting a student. It can be the client interview can take place at any time during the treatment. So the beginning starts with a script for the BCBA to follow, just walk the parent through that this is going to take about 30 minutes, asking for consent and just making sure that the parent really understands the rationale for why we're using the tool and why we're asking those questions. So really, this also allows us to monitor the risk on an ongoing basis. So the first section starts with reviewing the current status for the whole family. So questions include changes in stressors since COVID, any changes in resources that would affect services, such as, lack of transportation or a change in how they can transport. Did anything change with their Wi-Fi? Is telehealth even available to that family? Or do they have access to medical supplies? Just really kind of getting a handle on the family unit, what's going on with them at this point in time. And then the next set of questions looks at the family's risk of exposure and really examines their social behaviors. So it includes open-ended questions regarding household activities and interactions. Where are the parents working? Are they in the house? Do the kids go to school? Are they playing sports? Are they a real social family who's not really paying attention to any of the guidelines, or are they pretty tight-knit and staying home and working from home, and the kids are, telehealth? And then that also gives us information about is the family home? So if we do have to go to telehealth services, is the family there and available to be able to monitor, support, and help provide those services if that is kind of where the treatment information leads us. So in this section, it's all about information gathering. It's really a ton of open-ended questions to really gather that information, and it gives the BCBA a place to document all of that information. The BCBA may already have a good understanding of some of these questions, so we're really kind of relying on their clinical judgment at that point. I mean, they're trained in asking interview questions. They're trained in the FBA process, so we're really it's them using their clinical judgment to pick and choose which questions they're going to use, what's important, what do they already know about the family. Just a good place for them to keep track of, new things that come up, and sometimes even blaming it on the tool. The tool is asking me to ask you this. So for some of those uncomfortable questions, it kind of, it's repetitive. So if they have to ask it several times, well, the tool needs this information, or my administration needs this information. So it's just a way to give them structure and guidance. The next section looks at the COVID-specific symptoms. So again, these questions in this section is meant to be asked as often as possible. It's just like going to the doctor. Every time you make an appointment, they're asking you all the COVID symptoms. Have you traveled outside of the U.S.? Have you traveled inside the U.S.? Do you have any of these symptoms? And you can use that screener, obviously, every time the client comes to any type of service. But primarily, you're using it as a starting point to gather the information for both the team members and the family. After they get all that information, it really then leads to the client specifically and starts asking about the child in general. So has anything changed for the students? What is the child's daily schedule? What are they doing during their downtime? And then last, it's really kind of getting into those critical behaviors. Has behavior changed? Do we need to do another FBA? Is there any risk associated right now? Is there anything severe that is going on that we need to really change and come up with a crisis plan? So it gives a lot of guidance on just thinking through a lot of thoughtful questions to make sure that again, they're mitigating any risk that can happen while they're trying to determine, are they modifying a treatment plan, creating a brand new treatment plan, just to make sure that the services are the most appropriate for the whatever given situation.
One of the things I like about the paper too is that you guys gave a couple different kind of profiles or vignettes of therapist family kind of dyads, if you will, where it's Bobby is an RBT, and he stopped going to the gym to mitigate his risk, and the family works from home and blah blah blah. And then you have like the counter example of that, and what the different strategies would be or what the different possibilities that the agency or the organization could take with as a result of having that information, and how they might be able to respond differently to the needs of those kind of dyads. I thought that was really a nice part of the piece that you guys wrote.
Thank you. We really wanted to give as many examples and not prescribe what they should be doing, but give them enough thoughtful idea of things that we've even experienced. So I had to move an RBT from one team to another because of a different risk situation, or I've had to change out a BCBA, or the BCBA is telehealth while the RBT is in person, or we're doing just solely parent training and training the parent to do the intervention while the RBT is online. So we've gone through a lot of those situations. We really wanted to just give as many examples as we could right there to make it as real as possible without offering solutions, but more just guidance.
Very cool. Very cool. I was going to wrap up with asking you guys to provide some general advice to practice managers and owners who want to adhere to best practices as it relates to kind of navigating this whole morass that we find ourselves in. But I feel like that's just been the entire conversation here. So I don't, at the risk of being redundant, I guess what I would say is that perhaps as a parting question here is, I know you guys have kind of, field tested this screener a little bit. So if someone wants to talk about some of the responses I've had from people who've actually tried this out, outside of your kind of work group here, that would be a neat place to wrap up.
Matt, can I just ask, can I just draw, just for the sake of making sure it's really clear, because I think this was the most critical aspect we wanted to point out to your listeners, was the last section in relation to making it cohesive. If I could land here, would be the risk benefit component happens at the very end, where you're taking all this information and you're putting it into a graphic where it's the same level, parallel to the administrative, and then it's parallel at the clinical level, where you're saying, I documented these things and this is my strategy. And that is what protects you if something happens. So going back to our code and our responsibility to the code, by virtue of you having documented, I'm aware of the COVID is among us. And I did this very clear sort of funnel approach. And I have documentation of how I did all this. And that was one of the things we got in feedback, was this is the most difficult skill people, like the prescribing. This is actually the skill you have to be able to do for those higher level discriminations that you talked about in the possible combinations. Your graphic could look one way for one client and another, and how you mitigate whether you're doing routine testing or no testing is needed because everyone's virtual, will be very different. But this was one of the peer review PVACs we got, because their field is so young. People don't have the ability to do higher level discriminations for risk mitigation considerations. And so we want to really draw people and that was actually, Christy, I know, is going to talk about the content review, but that was one of the things we got. A lot of people gave us feedback that you would want to use this if you're a novice with someone who's experienced to actually tie your last question together, that was a reoccurring theme. A novice should use this tool or conduct risk mitigation with someone who actually, a supervisor. And this last section, I think, really ties that into what you were asking as a closing remark. Is that was, I would think, a reoccurring theme. And Christy, do you have any other things that you think would be helpful for Matt to know?
No, that's probably it. I mean, I could talk about surveys all day long. That was my old job before this, but I won't talk about data all day long. But she's right. One of the things that really stood out was that they said novice with supervision could do this. And we were just happy to have other people look at it aside from us, because we were so close to it at that point, and really now are so close to it. So I think it was really useful for us to go out to our peers and say, hey, what do you think? And their responses really did help us shape. The other thing that we learned a little bit about them without maybe them knowing it, just looking at the different responses that they took and say, oh, people who are have only 5 years experience kind of think this way, and people who have more experience think that way. And I think that also affects on how you use the tool. But what we really hoped was that it was going to be a tool for everybody. And I mean, that's kind of crazy to say, because once you're something for everybody, you're something for nobody. But we tried to be as comprehensive as possible so that it would be something that was useful for anybody who wanted to use it, and that people could take parts out of it. And just with all that stress that's going on, like Zahra said, and all the other things that are going on, and does my husband have it? And what are my kids doing? And why am I being a virtual teacher now? That we could take a little bit of stress off of somebody's plate at the end of the day to say, here, let us guide you, let us help you go through this. And these are the questions we asked ourselves, and it helped us, and maybe it'll help you too.
Very
yeah,
nice.
And I think just to add one final point to that too, because it is a comprehensive tool, but then when you use it on an ongoing basis, you're not necessarily reusing the entire tool. You're paying attention to the factors that are changing in that context at that time, so that you can adjust your decision-making process according to those changed factors only. So, it's comprehensive, but it's also targeted once you use it kind of in a more ongoing manner.
Great. Well, it's very clear to me that you guys put just a ton of time into this, and the level of authority to which you're speaking to these issues. It seems like you've gone out and gotten another degree in risk mitigation. So you guys maybe some university can give you like an honorary master's in public health or something like that, given the amount of work that you guys have put into this. So I just can't thank you too much for developing this tool for the field at this particular critical juncture that we're in. So having said all that, thank you very much for coming on the show and sharing this really valuable information with the audience.
Thank you for listening to the Behavioral Observations podcast with Matt Sikoria. You can find Matt's notes on this episode at www.behavioralobservations.com. We also invite you to stay connected with us on Facebook at facebook.com/behavioral observations and on Twitter at Behavior Podcast.